Management of deep vein thrombosis. Deep vein thrombosis is a medical condition that occurs when a blood clot forms in a deep vein. These clots usually develop in the lower leg, thigh, or pelvis, but they can also occur in the arm. Symptoms and the signs of leg or pelvis DVT include leg pain, swelling, erythema, and dilated superficial veins. Arm DVT has similar symptoms localized to the arm, and even some DVTs are asymptomatic. Differential diagnosis for limb DVT include cellulitis, lymphedema, chronic vein insufficiency, hematoma for leg DVT, and ruptured Becker cyst. Regarding laboratory tests, all children with venous thromboembolism should have a complete blood count and the baseline prothrombin time and the partial thromboplastin time to assess their coagulation status. In adults with suspected DVT, the D dimer level has high negative predictive value. If D dimer is negative, it rules out deep venous thrombosis, but the predictive value is not as well established for children. Venous compression ultrasound is the first line imaging test for suspected DVT. Renal and hepatic function test. Testing for APS includes evaluation for the lupus anticoagulant as well as anti-cardolipin and anti-beta-2 glycoprotein antibodies. This should be considered in patients with inflammatory disorders or those who present with thrombosis and no other obvious risk factors. When we came to management, once DVT is diagnosed, treatment is with anticoagulant. Initial options for anticoagulation in children include unfractionated heparin or low molecular weight heparin, followed by low molecular weight heparin or warfarin for outpatient management. The optimal duration for anticoagulation for neonates is up to 3 months, and the older children should receive 3 to 6 months of therapy. But patients with strong inherited thrombophilia, recurrent thrombosis, and APS might require indefinite anticoagulation or lifelong anticoagulation. Let's see unfractionated heparin. Both unfractionated heparin and the low molecular heparin act by catalyzing the action of antithrombin 3. Unfractionated heparin consists of a large molecular weight polysaccharide chains that interact with antithrombin 3, catalyzing the inhibition of factor 10 and the thrombin. The dose is 8 international per kg intravenous bolus, then 1/8 international per kg per hour with intravenous infusion. When we see the low molecular weight heparin or enoxaparin, enoxaparin is the most common low molecular weight heparin that is used for this purpose. The recommended standard starting dose for enoxaparin is for less than 2 months 1.5 mg per kg per dose subcutaneously BID. For more than 2 months 1 mg per kg BID. It should be avoided in patients with renal failure because the excretion is through kidney. After an initial period of anticoagulation with heparin or low molecular weight heparin, patient may continue to receive low molecular weight heparin as an outpatient for the duration of therapy, or this might be transitioned to oral anticoagulants such as warfarin. Warfarin is an oral anticoagulant that competitively interferes with vitamin K metabolism, exerting its action by decreasing concentration of the vitamin K dependent coagulation factor, such as factor 2, factor 7, 9, 10, as well as protein C and S. Therapy should be started while a patient is anticoagulated with heparin or low molecular weight heparin because of the risk of warfarin-induced skin necrosis. This warfarin-induced skin necrosis is a transient hypercoagulable condition which might occur when levels of protein C drop more rapidly than the procoagulant factors. So during the early administration of warfarin, it should be given concurrently with other anticoagulants such as heparin or enoxaparin. Dosing of warfarin should be adjusted based on INR, and the initial bolus is 0.1 mg per kg PO 24 hours apart for 2 days. Then based on INR level, the dose can be from 0.05 to 0.35 mg per kg per day. When initiating warfarin therapy, unfractionated heparin or low molecular weight heparin should be continued until the INR is in the therapeutic range for 2 days. In most patients, this takes 5 to 7 days, so we should have to overlap warfarin with enoxaparin or heparin for 5 to 7 days. The PT is used to monitor the anticoagulant effect of warfarin. The thromboplastic reagents used in PT assay have widely varying sensitivities. So the PT performed in one laboratory can be compared to that performed in another laboratory. It's difficult to compare PT performed in one laboratory with that of another laboratory. As a result, INR was developed as a mechanism to standardize the variation in the thromboplastic reagent. In general, a range of 2 to 3 is the target for the treatment of venous thromboembolism. INR range of 2 to 3. Direct oral anticoagulant or oral direct thrombin inhibitors or inhibitors of factor 10 are approved agents for the prevention or treatment of thrombosis in patients greater than 18 years old. This is a fixed dosing, oral administration, no dietary interference with vitamin K, no need to monitor laboratory tests, as well as initial results suggesting non-inferiority to warfarin in the fewer bleeding episodes that makes the preference of direct thrombin inhibitor or direct oral anticoagulant. But in pediatrics, this is not well stated, so it's not given.